When many of us in clinical medicine think back to our own training years, we often recall interacting with master clinicians who were skilled diagnosticians, thoughtful teachers, and role models of a compassionate bedside manner. What lessons do these master clinicians have to teach the rest of us in terms of how they learn, how their minds work, and how they became so good at what they do? I'm Vivek Murthy. Welcome to the Master Clinician Project. Hi everyone, welcome to this episode of the Master Clinician Project. The idea behind today's episode is to summarize the genesis of this channel, which really grew out of a line of research inquiry into peer-nominated expert clinicians. In this episode, we'll review a qualitative research study I completed in 2016 with two colleagues at the University of California, San Francisco. The first was Dr. Gurpreet Dhaliwal, who's a practicing internist, a master clinician himself, and professor of medicine at the UCSF School of Medicine. The second was Dr. Bridget O'Brien, who's a qualitative research expert and also a professor at the UCSF School of Medicine. Together, we performed a retrospective, qualitative, interview-based study of peer-elected master clinicians at UCSF. The link to this study is in the episode description. Our aim was to understand whether these clinicians had any consistent learning habits or clinical behaviors during their early careers, which might have accounted for their clinical excellence and distinguished them early on from their peers. Our hope was that by understanding the early careers of these master clinicians, we could perhaps help guide today's medical trainees and practicing faculty who set clinical excellence as an important career goal. So we'll start by stepping back and reviewing the existing literature on clinical excellence to serve as a sort of prologue for our work. Then we'll review the results from our study. And then we'll step back and try to understand how our results, which were these super interesting conceptual findings, can inform the daily learning programs and clinical work of trainees and practicing clinicians today. If the clinicians out there think back to your own training years, some of you may recall interacting with faculty role models who were considered to be master clinicians. Master clinicians are expert diagnosticians who have incredible funds of knowledge. Trainees see them as amazing teachers, they have excellent communication skills, and their interactions with patients, colleagues, and trainees reflects their deep emotional intelligence and humanism. They're sometimes widely published and sought after as speakers in their areas of expertise. But how did these physicians reach their elite station of practice? What were they doing during their early careers? What were their formative learning habits and key clinical behaviors? To try to answer some of these questions, we first turned to the emerging literature on clinical excellence, which at the time consisted of just 5 studies. In these 5 existing qualitative studies of master clinicians at academic medical centers, the authors interviewed peer-nominated master clinicians about their current attributes and clinical behaviors. These studies all seem to agree on several descriptors of master clinicians and themes of their current practice, including depth of knowledge built through self-directed learning, enthusiasm for patient care and teaching, advanced communication skills, superior clinical judgment, and humanism. Interestingly, the high quality of these studies and the very similar and rich descriptions they generated of what it means to be a master clinician has led to them directly shaping the election criteria of master clinician councils across the U.S. academic centers that have such councils. While these studies were interesting and informative in their rich descriptions of clinical excellence, they didn't answer the question that we originally started out with, which was, what specific activities or behaviors are important for trainees and faculty who aspire to become clinically excellent someday? While these studies certainly illuminated how the term master clinician could be defined, they left us wondering about what exactly happens at the point of divergence between the path leading towards becoming an experienced clinician and the path leading towards becoming an expert clinician. To try to address this gap, we conducted a retrospective, qualitative, interview-based study of 17 members of the Council of Master Clinicians at UCSF. Our study was published in the Journal of Graduate Medical Education. We conducted semi-structured, open-ended interviews asking these peer-nominated master clinicians about their first clinical jobs after training and about their early career learning routines, patient care activities, and unique clinical habits. We then performed thematic analysis on the interview transcripts, which yielded 4 parallel but overlapping themes of clinical development. Theme 1 was consistent learning efforts, where participants described learning by reading daily about the patients they were seeing in practice, by seeking out teaching roles, and by tracking patient outcomes over time. Theme 2 was rigorous skill development, where participants described actively growing their skills in patient communication, the physical exam, and clinical reasoning. Theme 3 was cultivating habits of mind, where participants described the importance of practicing humanism and humility, finding joy in their work, and applying rigorous thinking to clinical problem solving. And finally, Theme 4 was clinically rich environments, where participants described designing clinical environments that involved high patient volume, situations that took them outside of their comfort zones, peer networks to advance learning by sharing experiences, and learning directly from Master Clinician role models. I wish we had time to review demonstrative quotes from each and every one of the study themes and sub-themes, because, in my opinion, that's where the real richness and fun of the study can be found. But I'd like to zoom in on a few specific sub-themes and show you some excerpted quotes from each. We learned that these Master Clinicians had structured daily reading programs, and that they focused their reading around the patients they were seeing in practice. One clinician said, "I read every day. I always had a question in my mind from the day's work. Even if I came home post-call, I would read, even if it were just for 15 minutes. Another said, "I would jot down clinical questions on an index card, and I wouldn't go to bed until I'd looked up those 4 or 5 things. I was probably looking up something every day." These Master Clinicians also consistently identified that tracking patient outcomes was a formative clinical habit. One of them said, "When I wasn't sure what my patients had, I would write down their names and make sure that I followed up. If I wasn't sure what was going on, if I wasn't satisfied with the answer, I would make a note and I would follow it up." Another said, "We admitted a patient with pancytopenia and we thought that she had a bone marrow disorder. She suffered sudden cardiac death and on autopsy had aspergillus throughout her coronary arteries. She had no evidence of a malignancy. We came pretty close to not learning from that case." Our interviewees felt that tracking outcomes helped them find closure, identify mistakes including misdiagnoses, and better understand the natural history of diseases. Most Master Clinician interviewees told us that they held substantial clinical duties during their early careers. One clinician said, "I was a full-time clinician educator. I spent 7 months on the inpatient medicine teaching service and 2 months on medicine consult." Another, describing his busy early career practice environment, said, "Working in that emergency department where the volume was 60 patients a night, working as hard as I possibly could and unsupported by any other system, there was no other doctor in the whole building. Those 6 months were probably the most intense learning experience that I've had." Many of these Master Clinicians described learning from their peers by discussing clinical cases. They reflected that this on-the-job exchange of knowledge created a workplace culture of shared learning. One said, "I had colleagues who were all like-minded. We were lucky enough to be able to reflect with each other and ask for each other's opinions. That helped build the database." Another said, "We had groups that would meet and hash out clinical problems. We shared a lot of experiences amongst ourselves that way." If you can relate to any of the quotes that we just read together, or if you found them as inspiring and interesting as we did, you can find even more quotes supporting the other themes and sub-themes in our paper. Of course, all studies have limitations, and ours was no exception. First, our interviewees were peer-defined experts and not criterion-defined experts, and might not represent the most expert physicians if an objective measure of clinical excellence existed, which it does not. Second, our participants were faculty in one academic medical center, so our findings might represent a specific institutional context. Third, recall bias. We were interviewing people about things that had happened long ago, and memories can fade. Fourth, this was a qualitative research study which was meant to be hypothesis generating, and it was not intended or designed to conclude causation. In other words, we don't claim that doing these things will, invariably and alone, lead you to become a Master Clinician in the future. But at the same time, it's not a far stretch to imagine that they might at least give you some momentum in that direction. The question that follows from our study is, how can we translate our results into actionable behaviors that can be put into practice today by clinicians? In our paper, we try to tackle this question by crafting a table, and on the left-hand side of the table are the themes and sub-themes that emerged from our study. And on the right-hand side of the table are proposed action steps which are immediate derivatives of our findings. I've personally spent a lot of time reflecting on this table to design an intentional and planned daily learning program for myself. And if you find this study interesting and the results compelling, you might consider doing the same. This study represents an important first step in understanding the early career learning habits and clinical behaviors of master clinicians. We presented 4 categories of deliberate learning activities, each of which contains sub-themes that we've translated into action steps for residents, fellows, and faculty who set clinical excellence as an important career goal. And with that, we'll conclude this narrative review of our research study, which sparked the genesis of this channel. If you found this episode interesting and you'd like to read the original study paper yourself, the link is in the episode description. For all of our audience out there, thank you for tuning in. You can find us online at www.masterclinicianproject.com, on Twitter at mcproject12, or as an audio-only podcast on Spotify or really anywhere you listen to podcasts. Thanks for joining us on this episode of the Master Clinician Project, where we endeavor to learn from the very best clinicians. See you next time.